Okay, we're going to go ahead and get started. Good morning, everybody. I'm Victor Davila. I'm the director of the Global Health Center at the Department of Medicine. This week, we celebrate the 11th Annual Global Health Week at Washington University with several university-wide activities organized by the Global Health Center. The purpose of these activities are to foster engagement in local and global health-related discussions. Our grand round speaker today is Dr. Elvin Geng, professor of medicine in the Division of Infectious Diseases and director of the NIH-funded Center for AIDS Research at WashU School of Medicine. He is also the director of the Center for Dissemination and Implementation and co-director of the Dissemination Implementation Science Innovation Research Network at the WashU School of Public Health. Dr. Geng received his MD and MPH degrees from Columbia University, followed by postdoctoral fellowship training at the University of California, San Francisco, where he was faculty in the Division of Infectious Diseases and Global Medicine before joining WashU in 2019. Elvin is well known for his innovative research program in HIV and implementation science, and he is a principal investigator on several large grants from the Gates Foundation and the NIH. He has also co-authored over 240 peer-reviewed manuscripts. In addition to his outstanding research career, Elvin is a dedicated mentor. His well-known high IRI training program brings leading faculty from WashU and around the globe to provide training in implementation science for junior faculty. He also serves in several major advisory roles, including most prominently the WHO and the Scientific Advisory Board for the U.S. President's Emergency Fund for AIDS Relief, also known as PEPFAR. He is editor-in-chief of Implementation Science Communications, a leading journal in this field, and serves on the editorial board of several other journals, including PLOS Medicine and Journal for the International AIDS Society. On a personal note, Elvin and I began working right after he was recruited to WashU. Since then, we have written at least 2 large major NIH Global Health programs. The first project allowed us, the WashU team, to lead and coordinate the integration of hypertension care in HIV clinics in 6 countries in Africa. The second project in Peru has allowed us to lead a community health worker intervention program for hypertension control. Thank you, Elvin, for your vision, your leadership, and hard work with these 2 very successful research projects. Without further delays, it's a great pleasure to have Dr. Elvin Geng present today at Medicine Grand Rounds during Global Health Week. The title of his talk is Global and Local Lessons for Healthcare Improvements from the Front Line to the Top Line. Elvin, welcome.
Okay. Thank you very much, Victor. It's been a real pleasure to have the chance to work with you over the last 5 years and appreciate all the opportunities that it's brought. And I think our collaboration has been emblematic of my my time at WashU, which has been marked by great collaborations and a welcoming community. So for anybody new out there, bear that in mind. Okay, so I'm going to talk today a little bit about a specific project, but place it in the context of some of the thinking and debates in the D&I world at the moment that also sort of leak into the discussion about healthcare improvement and public health more generally. This project that I'm talking about is based in Zambia, but I think at the end I'm going to try to draw some threads to how it may resonate with our work here in St. Louis. I think I was supposed to show something like this, making clear my disclosures. And this is my outline. So 2 models of improvement patient and person-centered strategies. I'm going to use an example from Zambia, and then lessons learned. Okay. So I think broadly speaking, both in terms of improvement science and implementation science or implementation strategies to get evidence-based practices into use, one way to slice and dice this vast diversity of activities and interventions is to think about them as being kind of top-down or sort of bottom-up. And when I say top-down, I mean things like where systems and structures try to create and impose sort of constraints or regularity or systematization to the practice of healthcare workers, physicians, nurses, and other people. So one of these that I would say might fall into this category is something like audit and feedback, where you take data on performance and you look at individuals and you say, did you meet some benchmark or did you not meet some benchmark? Broadly speaking, guidelines might fall into this idea. Yesterday at the AI symposium, there was a lot of discussion about unexplained variability in physician practice. And for the most part, we tend to see those things as being things that we want to kind of control or do away with. So there are systems and structures and ways of imposing constraints on people and agents. So on the other hand, there are sort of things that are a little bit more bottom up, and I think sort of facilitation is an intervention that kind of falls a little bit more into this category. But the idea is that you want to harness creativity, you want to enable people, and then you want to use that to build the kind of teamwork that you would like to see to create changes in the norms and the structures of practice. So maybe starting from individual healthcare workers and looking to them as the engine of change. So, you can, these are kind of characterizations, and many implementation strategies kind of fall in between, right? Not completely one, not completely the other. But I think broadly speaking, this is one way to look at improvement approaches. I think the argument that I'm going to make here today is that maybe we are focused a little bit too much on the former, and there are opportunities both for improvement and research to think about the latter. And again, yesterday, I was worried a little bit about this in the discussion about AI, because a lot of AI is being deployed to kind of manage what might seem like sort of unruly human elements in the system, and identify sort of people that are deviating from practice, or in some cases imposing constraints on practice itself, right? And we think that these are sort of important things. I'm not saying that they're not important. I mean, but there could be reasons why we need to think about other approaches that are a little bit more bottom up. So why is bottom up stuff potentially important? Well, I want to start with 2 or 3 observations about the nature of healthcare that mean to me that bottom up approaches probably can't be totally avoided, and indeed might be something we want to harness. So this is a perspective that I wrote a few years ago about the physician as a street-level bureaucrat. And street-level bureaucracy comes from sort of the social work literature over the last 30 years, and it's an idea proposed by Michael Lipsky that the front lines of services, be they police officers, firemen, physicians, teachers, navigate a very complicated interface with the public. They're the frontline representatives of the system, and in that process, they invariably have to use a lot of discretion in the work that they do, and that discretion is made inevitable by the fact that there's always more work that can be done. And they have to navigate the needs of the sort of public and the logic of the system. So, I think whether or not a teacher suspends a student, or whether or not a physician sees a patient that's 15 minutes late, all these things are examples of discretion, and as physicians, I'm sure you can think of 100 instances every day where there are sort of boundaries between what you could do, what you should do, what you might want to do, what else you're giving up by doing it, in which you make that decision about whether or not you're going to do that thing, right? So discretion is the nature of practice. It can't be sort of completely systematized away. Okay, another argument is that why bottom-up might be important is that complexity is real and can't be sort of planned away. So people who study this consider complexity to be a feature of healthcare delivery, and complexity is not just that things are complicated, it's that things are complicated in ways that can't be totally predictable and are emergent. That is to say that if you put all the pieces of the puzzle together, the sum is not totally predictable just from the parts, right? So you can't say we have this many healthcare workers, this many staff, this much equipment, and then boom, I know exactly what's going to happen. You don't, and you never probably will. And I think frontline healthcare workers are the people who navigate and respond to those complexities that can't be foreseen and can't be totally predicted. And I think, again, as practitioners, you even if you've practiced medicine for 40 years, you will encounter on a daily basis something that is not exactly the same as before. And the diversity of those problems and issues that emerge is inexhaustible. So complexity and the demand for healthcare worker adaptation in that setting is also not avoidable. Okay, a third reason that we should think about bottom up, I think, is that is to harness this idea of appreciative leadership and appreciative inquiry, right? So this is work from David Cooper-Ryder, who has spent his whole career, he's a business school professor, writing about appreciative approaches. And I encourage you to consult some of his writing. He can do this much more eloquently than I can, but he talks about the fact that appreciative approaches are essentially, my paraphrasing of it is sort of not just accepting where people are, but meeting them where they want to be tomorrow, right? And it means appreciating strengths, but it also means sort of understanding those strengths and harnessing them and sort of pushing the boundaries of things. But it's supposed to lead to innovation, engagement, right? A worker in an environment with an appreciative approach is going to be much more engaged than perhaps one that's not. And it creates motivation, and it drives sort of what Cooper-Ryder and others consider sort of lasting change. Now, this might sound like in a medical school environment a little bit sort of soft, but there's actually quite a large literature on this. Nobody has done a randomized trial of this that I know of, but at the same time, there are a lot of publications on it. I'm waiting for somebody to do a randomized trial of this. And then to take this all sort of together, this is I think a very nice paper by Bill Miller and Benjamin Crabtree. I don't know them personally, but they're family practice physicians, and they in this article essentially complain about implementation science, and they say implementation science is generally stuff that comes from above the facility level, above the practitioner level, and you're telling us we should do X, Y, and Z. And in this article, they say that it would be much better to co-design the solutions with the frontline healthcare workers, to ask them and work with them to understand the problems in greater depth, and then realize that a lot of the practice variability is not just stuff that you can control away with individual behavior, but things that you have to do from the inside out to create change. And I think for those of you who are familiar with the implementation science conversation, this to me really rang true in the sense that, like the average implementation science project is, here's an evidence-based intervention. It works. So I'm going to do a study to see how to make healthcare workers do this thing. And that view, that intervention-centered viewpoint, inadvertently decenters the practice experience of somebody at the front lines, right? I mean, there was an article in the New York Times probably a year or two ago that I think it suggested that if you're a primary care physician and you did all the evidence-based stuff you were supposed to do, that your workday would be like 27 hours long. All right. So given that it is not possible to control and constrain your way out of the implementation problem, maybe we can think about how to incorporate more bottom-up strategies for implementation and improvement. So we need approaches that empower and enable individual providers and individual practices to both change their practice and to recreate the sort of structures that and the norms and the rules by which practice is delivered. Okay, so this is my premise, and now I'm going to shift into an applied kind of problem and my own sort of research work with many colleagues here and talk a little bit about that as a way to get into some of the practicalities of what might be possible in this space. Okay, so for those of you who may or may not know a little bit about my sort of research work, I've been involved in looking at engagement and retention in HIV care for many years, and more broadly in healthcare, but specifically with HIV often. And this is just a histogram from a paper that we published in CID probably more than 10 years ago. But this line of thinking was motivated by the fact that, you know, in the HIV response, 20 years ago, there was a really strong global investment in HIV treatment. And I always remind people that in 2004, as many people died from HIV as approximately people who died from COVID in 2020. It's approximately the same number. But the world stopped for COVID, and the world, in some places, came to a grinding halt for HIV, but in many places in the world it didn't because the epidemic was much more concentrated. But in 2004, a global sort of movement to treat HIV began, and in large part was kind of anchored by the PEPFAR program from George Bush and other sort of multinational donors and things like that. And so HIV treatment was scaled up around the world at a time when many people thought this was like totally impossible. I mean, in the United States, people were getting genotypes before each, you know, every time they changed a regimen or had a drug interruption, a treatment interruption, and many people, including Paul Farmer and others, basically demonstrated that all you need to do is the bare bones minimum, and you will save people's lives. And that was sort of a call that the world cannot kind of turn away from. So, you know, in 2005 and 6 and 7 and 8, I had the pleasure of working with some colleagues in Emberara, and we did clinic-based research. We set up an EHR at the clinic, and we also did clinical care. And we started like dozens of people in HIV treatment every day. Like you go to clinic in the morning, and you'll start 15 people by lunch and another 10 people by dinner time. But one of the things that began to emerge was like, despite the fact that people were on life-saving treatment and people were obviously benefiting from it, many people didn't stay in care, right? There were a lot of people who after a year or 2 years or 3 stopped coming back to care. And we had an interest in understanding why, and one of our sort of research programs was looking for people who didn't come back and spending time and energy to find those people and then talking to them. Doing interviews, but also just surveys and other things to understand why people were not coming back. And before I tell you about this slide, it turns out that this problem of retention is a sort of essentially it's an endemic problem to chronic health care. I mean, in the United States right now, the estimates that I've seen vary, and the cardiologists will know better than me, but the number of people who have their hypertension controlled is somewhere between like 25 and 50%. And that is, I mean, it's lower, a lot of that is not, more than half of that is due to attrition after they come to care, right? So this problem of retention is not Africa specific, it's not HIV specific, it's a general problem. But nevertheless, we did, many surveys. We did probability samples, so we made claims that the things that we found were representative, and we looked hard for people. And it turns out that you can find almost anyone when you look hard, and people are happy to talk about why they didn't come. So here's the dilemma. Okay, people don't come for a lot of reasons. So here I have just the specifics. I think. These are patient-reported reasons for not coming back, and some of them are structural, like number one, the blue bar is transportation. The blue bar is work requirements made picking up medications difficult. Yellow is psychosocial. Red is clinical. I spent too much time at the clinic. I intended to go, but things got in the way. The staff did not treat me with respect and things like that, right? So there are many, many factors at both the societal, structural, and clinical level and individual level that get in the way of retention. So what do you do, like as an intervention? Because, by the way, this is like K, and you're supposed to propose an intervention when you're done with your K. So like, what are you going to do about a problem that has so many determinants, like so many causes? You can't solve all of these things. But as time went on and we did more work into this, we developed a hypothesis. And I'll tell you about what drove that hypothesis, which was this study. Well, it helped firm up this hypothesis. So raise your hand in the audience if you're familiar with like choice experiments or preference methodologies. Okay, we got like 50% about, which is great, because I would say like a few years ago, it might have been like very few. But nevertheless, preference methodologies come from economics and marketing. And in economics, the overarching, if there are any economists in the audience, you can take issue with my characterizations maybe, but basically, economists believe that human behavior is driven by utility maximization. And so utilities are internal units of happiness that everybody has that are not directly measurable but exist. And utilities is a unit of satisfaction or happiness that you derive from consuming some good or service, okay? We all get happy when we buy stuff. We get like food that we like. We get you get services, various things. And, but of course, you can't have everything. You don't have enough time to have everything, and you don't have enough money to have everything. So all of us make utility maximization calculations inadvertently in our heads, so the economists believe. Now, everybody's preferences are different. You might like Thai food, and you might like Mexican food. You might like to go on vacation someplace exotic, and you might like to go for a spa or something like that. But our preferences are different, so our utility maximization algorithms in our head are different. But so since you can't measure utilities, they came up with a very clever way of simulating these utilities, right? So instead of watching you behave, how you find out about someone's utilities is that you ask them to choose between two versions of a good or service, right? So if you want to eat out, here's a restaurant A, restaurant B, which one would you rather go to? Restaurant A's got this much money, it's located here, it's got this atmosphere, it's got this kind of food. Restaurant B, different. And when you ask people that and they choose one, and then you scramble the attributes, and you ask them to choose again, scramble the attributes, ask them to choose again, what you will find out from their choices is what attributes of this good or service people want. and it quantifies how much they want it, right? You can quantify how much you want a good or service that way. So unlike qualitative work where you can say like, yes, I like Thai food more than Mexican food, and then I like Mexican food more than Chinese food. Okay, fine. That's a qualitative observation. Choice experiments can give you a quantification of how much more you like Thai food than Mexican food, and then how much more you like Mexican food than. So these things are being applied. I mean, traditionally they're applied to study consumers, right? And in the last few years, we've begun to think of public health and medicine as recipients of public health services also as consumers in a sense. I don't fully endorse that sort of lens, but at the same time, if you do that, it asks you immediately then to ask, well, what do these folks want? And how do they want it? And how can I deliver it in a way that's going to maximize their uptake? Okay, so this is a choice experiment about these are all patients that are out of care. We asked them, which clinic would you be more likely to go to, clinic A or clinic B? Which clinic would you be most likely to return to, clinic A or clinic B? And the attributes on the survey are staff attitude, opening hours on Saturday, opening hours in the afternoon, refills. At the time, it was hard to get a lot of medication, so 3 versus 5 months and then 1 versus 3 months. Distance, how far the clinic is from your home, and then wait, okay, how long you would have to wait if you got there. So these were all attributes taken from qualitative interviews and literature, and were considered like many of the main drivers of how people behave. And on this scale, to the right is happy and to the left is unhappy, and it's units of utility. Okay, so they're quantifiable, transferable sort of units of happiness. So you can see here that like the staff nice versus rude is very important to people, and it's worth, because these quantities are like they're on the same scale, it's worth as much to people as basically getting 5 instead of 1 month of refills, so that the size of that bar. And then if you were to do formal willingness to pay analyses on distance and waiting, it's worth 40 kilometers of travel, and it's worth over 10 hours of waiting time. So if you see a nice provider, you would rather go 40 kilometers further to a clinic where the providers were nice than one that was 40 kilometers closer where the providers were not. And you would rather wait 10 hours to see a provider who was nice than one who was not. Now, these are patients who were, about 250 patients who were out of care, so this is not like every patient in clinic. These are patients who had dropped out. But the choice experiment helps us quantify a qualitative observation. I think I need to hurry. And that helped us lead to kind of like a sort of a theory or a hypothesis of patient experience effects, okay? And this is a bit complicated, but let me just say this real quick. Actually, I'm just gonna go to this one. So social and structural barriers exist, okay? And many of those are difficult to change, like improving the road infrastructure in a place, or improving public transportation in St. Louis or in Uganda is not something that's immediately changeable by people who work in the health system. I mean, society and economic growth and things like that in general are supposed to make those things better. But you can't change those things immediately. Stigma and things like that, psychosocial things, are also hard to change. There's been a huge amount of research on how to reduce stigma. I mean, stigma is an important factor, for sure. But there have been very few convincing studies that show that you can do some kind of intervention and change stigma, and therefore change healthcare behaviors based on that. But what you can change is the nature of the provider-patient interaction. And the hypothesis is that the more severe the structural and social barriers are, the more important that interpersonal interaction between service recipients and healthcare workers becomes. And in other words, and I think we, as physicians, we probably all know this intuitively, if you come to clinic and you have left your kids at home hungry, and you took the bus, and the bus broke down, and you thought it would take 2 hours, but it took 6 hours to get to clinic, and you're 15 minutes late to clinic, or you're half an hour late to clinic, if somebody scolds you for being late, it will magnify all the difficulties that you face that day, right, in terms of your future willingness to engage. If you're treated with kindness or you're welcomed, it will ameliorate all of those things. And when I did HIV primary care for many years, which I don't have a clinic now, but we were always behind, like always behind schedule. Like nobody would show up for 2 hours and then like 5 people would come at once. So you're always behind. And I was always amazed by the fact that if you were waiting in the waiting room for a long time and people were kind of agitated and there was a bad interaction with a healthcare worker, the whole thing could explode, right? But if somebody went and said, hey, look, you've been here for an hour, it really sucks, we're really behind, and we're doing our best to get to you, it diffuses the whole situation. And the idea is in an environment where things are really challenging from a structural and a social point of view, that interpersonal interactions have an outsized effect. Okay. So how do we test this idea? So we working with Izukanji Sikazue at CIDERS and Kombatende Sikombe, who is finishing up his doctoral studies now, Charles Holmes, and Alok, Modi, and others, we embarked on this attempt to test this hypothesis, okay? Now, we'd been working with the Gates Foundation for some time, and so we got a grant from the Gates Foundation to essentially design and test an intervention in a trial. And I will say to you right now that there was no way this trial would have been funded by the NIH. But because the foundation was kind of had invested in this group before and was interested in this hypothesis, I think we were able to eventually work out a study to do this. Okay. So how do you do this? What is the intervention? Like what do you do? Okay, so we spent probably a year or a year and a half first defining how you would touch a health system to change like behavior of the health system in a real world setting. And we undertook sort of a mixed methods approach using human-centered design and to develop kind of the approach. Now, design is another one of those things that I think sometimes in people who sort of come from a natural sciences background feel like maybe it's a little squishy. But to be clear, I was a skeptic as well. But at the time, the Gates Foundation was all into human-centered design. They were like, everybody needs to do human-centered design. And I was like, we don't need to do human-centered design. We got this. And they were like, nah, we're going to send you a human-centered design person from Seattle. And we were like, okay, fine. And so I won't tell you how much the Seattle human-centered design person costs, because like you could like feed a village in Zambia for like a month. But nevertheless, they were like, we're going to pay for this. So this guy came. And we spent a lot of time working with him and with a group of healthcare workers in Zambia to kind of like think through how you would design something like this. And I will say two things. Number one, a lot of design is culturally specific, right? So you need to understand the context really well. So I don't think that necessarily somebody like from Seattle who's worked in like ergonomics is going to be the right person, but he did teach our entire group about the logic of the approach, and then we were able to like work together to bridge the cultural and the technical aspects of it. But I'm going to say a few words about this design process real quick before moving on, and then get to kind of the gist of things, which I probably need to get to. But design is rooted in the notion of like working together and creating first and foremost an affective foundation for working together. right? So the first thing you're supposed to do is harness and foster empathy. And you just call for that. And then you repeat that, sort of idea over and over again, and you create an environment where empathy can grow. And if you think about it for a minute, like if you think about like psychologists, right? There's a whole world of slow decision making that's based on, this is Daniel Kahneman, thinking fast, thinking slow, rational approaches. I think A, I think B, and therefore C. More than half of our brain is fast approaches, which are based on like intuition and instinct and things like emotion. And when we don't harness those things in our sort of research on how to change organizations and behavior, we're leaving at least half of the stuff on the table, if not more. And you could argue that in healthcare, where you're just like going, like a lot of the stuff that we do is not based on the slow thinking system, it's based on the fast thinking system. So by harnessing an effective foundation, you create this thing to work together. Okay, so I'll be quick about this, but I would say three things about this design process. And this is published in a paper by Barris, which I should have put the reference in here in J-AIDS in 2019. But we went into it with this idea of sort of how might we interact with the health system to help healthcare workers essentially be nicer. And there were three parts to it. How do you facilitate that process? How do you create a system or information around that process to make it visible? And then how do you kind of reinforce that approach, right? And there, in a design process where you use methods, unlike qualitative interviews, you create real scenarios and people walk through them together. It's like simulated ethnography. It's like a patient comes, you're the nurse, what happens during the day and things like that. It surfaces a lot of resonances and resistances to this process. So I'll say that one of the three things really came out in terms of the resonances. Number one, people go into healthcare work because they want to do right by people. Like that's a big part of the motivation all over the world. And number two, that people feel good when they have good interactions with, like healthcare workers are burnt out, but they feel good when someone feels good about the care they received. That's true sort of, I think, everywhere in the world. And there were a few others, but there's also lots of resistance, right? There are healthcare workers who say, patients are like this. And then they have a caricature of like the worst patient. Or they say like bad patients who don't do what they're supposed to do have to be punished. Otherwise you can't, how do you know these patients are gonna do what they're supposed to do? And things like that. But I'll say that during this process, in a co-design process, the community that's come together to do the design raises the problems and also works to solve them. And some of the solutions that the main insight, well, not the main insight, but one of the main insights that we left with at a conceptual level was we went in there thinking, how do we work to get people to be nicer to patients? And we left with the understanding that you have to center healthcare workers first. Like healthcare workers have to feel heard at a minimum in order for them to transform their own practices, which they actually really want to do. Okay, so here's the intervention, a multi-component intervention based on capability, motivation, opportunity, the framework, implementation science. So from a capability point of view, we would do training and coaching or facilitation. The facilitation was based on what the healthcare workers wanted from the facilitator. There was a gentle facility level incentive, so a comparative thing where facilities could see what other facilities were doing. And then there was, importantly, a client experience feedback. So we instituted exit interviews, and then you brought the exit interviews with a 12-item instrument about the experience back to the clinics. So they have staff meetings already. They talk about their viral load suppression, but there was no data stream about patient experience. So we just added this to an existing improvement process. All right. This is the patient improvement scale, the patient experience scale. It's adapted from a number of existing scales. I won't belabor the details, but the intervention was rolled out in the province of Lusaka in Zambia, which has so this is sort of the largest province in Zambia, and these are the largest clinics, the largest 24 clinics in Lusaka. And the total number of patients that were touched by this intervention was 170,000 patients. And over the course of the 2-year study, a little bit more than 2 years, it was rolled out in a stepped wedge design, sort of over 500,000 patient encounters. And this is a I'll just go to this one. So one of the ways we wanted to measure patient experience, which is notoriously difficult to measure, is that we sent patients that were trained on this instrument to the clinics who were blinded to the intervention condition of the clinic. And the clinic was blinded to the intervention, or to the fact that these patients were there had some training and evaluation. It's like, if you're the New York Times food critic, the restaurant doesn't know you're the food critic. And the food critic doesn't know if the restaurant has had an intervention or not, I guess. But nevertheless, these are the satisfaction, these are the patient experience scores in the control condition less than 6 months and greater than 6 months. And I think one thing that's very telling here is that even though the medians don't change that much, the tails changed a lot. And we considered a score of 8 for complicated reasons to be, the threshold between like a good and a not good visit. In the control condition, sort of something in the range of 1 out of 6 visits was considered not good. And after 6 months of intervention, that had gone down to 2%. And so, this is 1,000 kind of blinded evaluations. Retention. This is retention at 15 months. Defined as whether or not you were still in care and making appointments or in a window of time around that interval. So the overall improvement of that was about 6%, and that effect varied in size from about 12% in people newly starting ART to a little bit less in people who were in care for a longer period of time. So overall retention number needed to treat somewhere in the range of sort of 1 in 20, sort of 20 to 10. And these are statistically significant. This is published in Lancet HIV, I think not too long ago, but again, probably needs a reference here. Okay, so we talked about bottom up. What is bottom up? Okay, so the bottom up is if work that's done that emerges from sort of healthcare workers and frontline providers changes the structures. And what are the structures? Structures could be, actual HR structures, or they could be like things like norms in a facility. So is there evidence that that this changed structures or norms? So after the trial was over, because this is a big health systems intervention, right? So ministry and people were involved. There was an attempt to hand over to the ministry, so that some of these functions were taken up by the facilities, and the research, the people involved in facilitation, so that were part of the research team, stepped away and were no longer like actually in the clinics doing any kind of facilitation work. And this is the sort of patient experience surveys done at baseline, sort of before sort of crossover in the stepped wedge, at the end of the intervention, and then somewhere about a year after the last intervention, the last sort of project-related interventions at the facility occurred. And this is about actually 3,000 patient experience measures post-intervention. But it is, on average, the effect appears to be maintained, and there's ongoing research to understand the mechanisms for that and the stability for that. I would say that in terms of structures and norms and policies, this study did also produce a round of kind of policy change in country, and the team led by Competentes Combe and Njekwa Kumba and others there was a follow-up Gates Foundation grant to essentially prospect these results within the health systems environment, and many health systems sort of documents and norms from the sort of differentiated service delivery framework, client experience training manual, feedback tool, and these things like that were incorporated elements of the study and the study finding into these things. And I have listed here the sector and level, workforce training, provincial SOPs, et cetera. And outside of Zambia, this also helped spur a conversation around person-centeredness and patient-centeredness in the HIV world. The IAS has a person-centered training academy that they held first in Lusaka with the folks who led the study, and then subsequently in Atlanta. And that's still a program that's ongoing from the IAS. And the WHO has incorporated good practice statements first in 2021 and now again in 2025 around person-centered care related to the sort of study findings, sort of changing kind of norms and targets at a global level. So that story continues to unfold. As many people know, the global environment for HIV treatment has changed drastically in the last 6 months. Many programs have taken big hits. Organizations have lost a lot of their workforce. Some of them got some of them back. Some of them got some of them back, and then lost them again. And it's a precarious time. And I think that overall the outlook for the global HIV response has to be considered shaky at best. I think it remains to be seen whether or not sort of person-centered approaches mean more or less in that kind of environment. Okay, I'm going to end with a couple of final reflections about this. This is retention in HIV care in the United States. This is from the Kaiser Family Foundation, and I don't know if the resolution is good enough, but the United States is obviously not like top of the list here in terms of retention. So we've also done quite a bit of work around this in the United States as well that I'm not presenting today. But what I do want to say is that information and the diffusion of information flows in ways that we do and don't anticipate, right? And so we presented the study results from the trial at CROI, which is an HIV conference, I don't know, 2 years ago or so, or 3, maybe 2. But subsequently, I had met Ndwele Jolly at a holiday party at Tom Maddox's house, and we had talked, and we got to know each other a little bit. And we didn't talk about this at all. And then some months later, he emailed me and he was like, I came across this abstract. This looks really interesting. And I'm very interested in what this means for St. Louis. And I said, great, we should get together and talk about it. So we have in our group with Ann Trollard and others have worked with the Integrated Health Network over the last year or more than a year to better understand sort of the healthcare workforce in the federally qualified health centers, and to try to better understand the experience that they bring to patient-provider relationships. So we did some of the same things we did here. We did interviews, we did a choice experiment with healthcare workers, and we produced kind of a report that it's continuing to be a topic of some discussion. I do want to show you this result, okay? This is a preference study. I think this is, it's not huge, it's less than 100 people. But again, like the previous graph, to the right is happy, to the left is unhappy. These are people who work at the clinic, okay? This includes doctors, nurses, and others, including sort of HAs and things like that. So again, more preferred, less preferred. And the question is, in terms of sort of retention and satisfaction, what if these were two clinics that you could choose a job at, which one would you choose? Okay? Which one would you more likely to take a job at? And the dimensions were staff support for each other, like camaraderie among the staff, involved culture, meaning that like you get to say or pitch into the practices and the processes at the clinic. High worth versus low, this is like how you perceive you're valued by leadership. And then there's money, right? 10% more, 10% less than average for your role. Flexible schedule, meaning that this is sort of getting into some of the specifics with these clinics, and then workload. So I think what you see here is that, so first of all, money matters. But what's much more interesting than that, because money always matters, is a lot of other stuff matters too. And a lot of other stuff is worth actually a lot of money. So what this is saying, these results are saying, is that if you were to let's put it this way, if you had an involved culture and you felt valued by your leadership, if you add up that 0.6 and 0.74, it's worth as much, if not more, than 10% salary to people. Like, if you had those things, you would take a job that paid you 10% less. You'd rather have that job because you have those things. You have an involved culture, and you have you feel highly valued. So it's not that money doesn't matter, but I think the more important lesson here is that many other things well within the control of the it's not that like those things are, to create those things you need money anyway, but nevertheless there are things that matter as well. And in many ways we found this sort of impulse for bottom-up involvement and improvement in the clinics here in St. Louis, just like very similar to some of the experience in Zambia. So more to come on that, but an exciting area of thought and thinking. Okay, so let me just say that this is kind of like my take-home stuff. I think in resource-limited environments where there are many barriers to care, the interpersonal interaction is really important. It can make things better, or it can make things worse. Centering clients or patients also means, to the extent possible, centering the healthcare workforce. And there's methods to do that in implementation science from the bottom up, but we need to pay more attention to those approaches. So thank you all for your attention. These are some of the names of folks that we worked with, my colleagues in Zambia, Izukanji Sikazwe, Sanders Mbeza, many others, Kombatende, folks here, Alok, others, and then funders at the Gates Foundation and in other places. So yeah, this is I guess I'm supposed to put this up. And this is, I ruminate about things on Substack sometimes related to implementation science, so if you're otherwise interested.
Thank you very much, Elvin. I think we have time for maybe one or two questions. Anybody in the audience? Mark?
Thanks a lot. Great presentation. Can you talk about like the self-organizing aspect of systems, like complex systems like healthcare, but with this tension with entropy, like things when you talk about the clinic where like it can just become chaos, and like that feels like this balance you're trying to strike of letting the system self-organize and grow in the bottom-up way, but also not spin out of sort of control because some of the incentives will sometimes be misaligned with what's best for patient.
Yeah. I mean, I definitely, so I think that taking a realistic view on this is that like improvement is about a balance of both, right? Like we do need structures and systems, and we all know that like healthcare is on the verge of tipping into chaos at any given moment at anywhere, right? Like one thing goes wrong and the whole thing goes into chaos. So there needs to be systems, and I'm not saying that like I don't support, for example, guidelines. We all need guidelines. But I also think that at least in implementation science, many of the strategies that we think of are ways of controlling and constraining healthcare workers. And we haven't fully harnessed or understood ways in which you can build on the realities of healthcare worker agency in environments of unpredictability and complexity to harness their discretion in the quote unquote right way. I don't know if that's satisfactory, but.
Yeah, I mean, I'm just trying to like, I think it's better data to help like feed that information up. Just thinking like our practice here, like how to feel empowered when you have to like click certain buttons in ethics. I mean, that's a tension that I feel like, your goal, you can't close on the visit because there's some button that's not clicking. And you're like,
Well, okay, but this is important, right? And this is actually what we were talking about yesterday in that AI thing as well, because so your experience as a healthcare worker, so we derive satisfaction, joy, and agency from work that we feel like we have control and mastery over, right? And we don't want to design healthcare delivery systems in a way that robs people of that. And it's easy to see how it's easy to see the temptation to do that, right? Like not let something close because you haven't clicked something somewhere. But that's like to a doctor or a physician, that's torture. It's like, there's like patients waiting and like you can't close this you just want to smash the computer, and so it's a really important issue, and I think especially in the United States where we invest so much time and attention on training individuals, we can't then imagine that we can robot our way out of the problem.
Thank you so much. If you have any other questions, come down here. Elvin will say a few minutes, but thank you, everybody, and have a wonderful day. Thank you, Elvin.